Can I start? Okay. I think we discussed hypernatremia in the last task. So in continuation of hypernatremia, I thought it would be better that we discuss polyuria today. So the next 45 to 50 minutes, what I'll be trying to do is to tell you how we approach the problem of polyuria. Though we always uh, talk about polyuria, I don't think we really discuss polyuria. So what will be, the slides are not moving. I don't know why. So the objectives of my presentation today will be just to tell you how do you define polyuria, what is the prevalence of polyuria in specific populations, what are the common causes, how do you classify polyuria, and how do you approach to diagnose cause of polyuria in a systematic manner. And we will briefly touch upon the management of diabetes insipidus. So let us see what is the definition of polyuria. When we say polyuria, it's a generalized total increase in 24 urine volume, urine output exceeding 3 liters per day in adults, 2 liters per meter square in children, which gets translated to 1.5 to 2 ml per kg. This should be differentiated from nocturia, which is an abbreviation of nocturnal polyuria. Nocturnal polyuria is defined as nighttime urine output greater than 20% of the daily total urine volume in the young and more than 33% in the elderly at night, or more than 6.4 ml per kg. As we all know, normal, there is a increased response to ADH, increased concentration, and the urine pass at night is slow. Unless you have got some obstructive voiding symptoms or something, the normal physiological mechanisms shut down the urine flow at night. So if somebody passes more than 1/3 of the volume at night over the age of 65 and 1/5 of the total urine volume at night in less than 65, we can call it nocturia, which is nocturnal polyuria. But, always there's a confusion between polyuria and increased frequency. When you ask the patients about, do you have increased volume of urine at night, they usually say yes. But it is usually the frequency that they mean and not the volume. So differentiation from increased frequency is important, which is scientifically termed as polyuria. So this differentiation is important because the approach to the problem is also different. So when you say polyuria, it is abnormally frequent urination once every hour or two, but the volume passed will be low. So these are the few definitions we have to keep in mind. In patients with low urinary tract symptoms, polyuria is around 22%. In poorly controlled diabetes, is around 38%. In diabetes insipidus, is around 25%. What are the factors that influence? Age is an important factor. As we become older, it is around 79%. Underlying medical conditions, diabetes insipidus, chronic kidney disease, with a defective concentrating capacity, the urine passed total will be increased. And this polyuria has an impact on the quality of life. If somebody is in the office, they can't be passing. It's a real disturbance for them in their work. So that's why people are bothered. They come to you and say they have polyuria. So when we say urine volume, the volume of urine is composed of two parts. One is osmolar clearance, which we'll be discussing soon. And the second will be free water clearance. What do you mean by osmolar clearance? See, if you and me take 10 grams of glucose, to maintain homeostasis, this 10 grams has to come out of your system. So how does this 10 gram come out? It cannot be passed as sugar, isn't it? So it has to be dissolved in a solvent, which is water, and the volume of water required to that excrete 50 gram is the osmolar clearance, because the volume of water that contains the solute that is to be excreted. Similarly, if I ingest 60 milliequivalents of sodium daily, that 60 milliequivalents of sodium has to exit from my system, and that has to be dissolved in water. So that is an osmotic solute. So that type of volume which is required to excrete the solute is called as osmolar clearance. But we also know that the volume of urine is not only for osmotic excretion, it is also for maintaining water balance. So there is a free water clearance. That is the volume of urine that is excreted without solutes. So if you see this diagram, the volume of urine has two components. One is the isoosmotic urine, which contains the same osmolar concentration of solute as in plasma. In addition to that, it has got a water component which does not contain any solutes. So urine volume is composed of two components. One is a solute, that is the volume of water required to excrete the solutes, which is called as a solute diuresis. In addition to that, to maintain the sodium balance, the water has to be adjusted, and that increased water excretion can also contribute to increased volume. So when you say polyuria, it can be either a solute diuresis or it can be a aquaresis, that is in only water alone. So polyuria, again to repeat, is made up of two components. One is the volume of water that is required to excrete the solutes we have ingested and the metabolic breakdown solutes, and the water that has to be excreted or to be retained to maintain the plasma osmolality. So these two components we should keep in mind. So let us see what are the abbreviations and equations we come across in polyuria. V is volume of urine liters, U is urine osmolality, P is plasma osmolality, C is osmolar clearance, and CH2O is free water clearance. So volume of urine passed in 24 hours is equal to free water clearance plus osmolar clearance. So how do you find out the osmolar clearance? If you find out the osmolar clearance, it's very easy. Free water clearance becomes, we know we can measure the 25 urine volume, that minus osmolar clearance with the free water clearance. So how do you calculate the osmolar clearance? U osmolarity into V gives the volume of water that contains this much of solutes. That has to be divided by the plasma osmolarity. That gives you the osmolar clearance. So osmolar clearance is found out by urine osmolality into volume of urine 24 hours divided by the plasma osmolality. The V into U osmo, hope you are with me. So if somebody is diluting urine to the maximum at 50 osmoles per liter, to exceed the 600 osmoles, we need 12 liters. That means the urine output can range anywhere from 500 ml to 12 liters, depending on the diluting and concentrating capacity of the kidney. If the urine osmolality is 900 and the osmol production is 600, you need only 750 ml to excrete the 600 osmoles. So even then the solutes can be excreted. If the urine osmolality is 100, on the other hand, and the osmol production is 600, the volume required will be 6 liters. That is, with a low diluting capacity, patients or people tend to develop polyuria to excrete the normal osmotic load of 600. So how do you find out the urine osmolality? When we discussed fluid therapy, we said that urine osmolality serum osmolality is equal to 2 into urine sodium plus urine potassium plus blood urea nitrogen plus glucose. Urea nitrogen divided by 1.4 or urea divided by 6, glucose divided by 18. The same formula is applied for calculating urine osmolality also. Urine osmolality is equal to 2 into urine sodium millimoles per liter plus urine potassium millimoles per liter plus urine urea nitrogen divided by 2.8 plus urine glucose in milligram per deciliter by 18. The same formula, instead of blood values, we give the urine values. But we know that in non-diabetic, non-glycosuric patients, urine does not contain glucose. So the simplified formula will be 2 into urine sodium plus urine potassium plus urea nitrogen by 2.8, or we measure here urea, so it will be urea by 6. The 2, again to repeat, sodium is existing as sodium chloride, potassium is existing as potassium chloride. So the osmotically active particles are double that. That is why you put this 2. That is, one sodium chloride has 2 osmotically active particles. One potassium chloride has 2 osmotically active particles. So you are multiplying 2 into urine sodium plus potassium plus urine urea by 6. We also have osmometers which can directly measure osmolality. We have one at our hospital. We can directly measure the osmolality. So when we measure the osmolality and we calculate the osmolality, the measured osmolality minus calculated osmolality is given as osmolar gap. There is a normal urine osmolar gap which can vary from 10 to 100 osmoles per kg. So to repeat, we have to measure the osmolarity in suspected situations. We have to measure the osmolarity using an osmometer. The principle employed is a freezing point depression method. You can calculate the osmolarity based on the formula 2 into sodium plus potassium plus urea. The measured osmolarity minus calculated osmolarity is the osmolar gap, which can be anywhere between 10 to 100. So if the measured osmolarity is higher than 2 into sodium plus potassium, that indicates the presence of other solutes, usually increased quantity of urea. What are the causes of solute diuresis? We said if the osmolar gap is wide, we have to suspect the excretion of other solutes. What are the normal solutes that are excreted than sodium, potassium? In patients with renal dysfunction, we know that urea gets excreted in the urine in large amounts. So increased urea is an osmotic solute. Diabetes mellitus, you have glucose coming into the urine. When you use sodium glucose transport inhibitor use, it controls diabetes by excreting glucose in the urine. For conditions like hyponatremia, if you are administering urea, that can also result in increased excretion of urea. Radio contrast can be excreted in urine, contributing to high osmolarity. Hypercalcemia in primary hyperparathyroidism, multiple myeloma, etc., can have high urine calcium. If somebody is on right tube feeding, and if you are giving high protein, that can generate increased urea load, result in solute diuresis. Somebody is recovering from acute kidney injury, as we earlier said. The tubules have the inability to concentrate urine. So the volume will be high. See, once you recover from acute kidney injury, acute tubular injury, urine volume will double every day. So if somebody is passing 500 ml, then becomes 1 liter, 2 liters, 4 liters, 8 liters like that. That can also result in a solute diuresis. What do you mean by post-obstructive diuresis? Somebody has got a BPH. Both ureters are dilated, obstructed. You are leaving the obstruction suddenly. What will happen is all the retained solutes will need to be excreted. That can produce increased volume, result in polyuria. When there is an obstruction, the tubules are insensitive to the tubules become sensitive to ADH and they retain. Once they relieve the obstruction, the sensitivity to ADH is lost. That can result in polyuria. If somebody has got raised intracranial pressure, when you give mannitol, we all know that's an osmotic solute, which is not metabolized. It gets excreted, and that can also contribute to high osmolarity. Needless to say that if you use 3% saline or normal sodium chloride in large volumes, it gets excreted in the urine to contribute a high volume. All these causes are reasons for increased osmolar clearance. So let us see by example how you calculate. Osmolar clearance is equal to urine osmolarity into volume of urine 24 hours divided by plasma osmolarity. So if a person has a urine osmolarity of 250 and a urine volume of 3 liters per day, and a plasma osmolarity is upper limit of normal 300, the osmolar clearance would be 250 into 3 divided by 300. So you get a volume of 2.5 liters per day. So this patient needs around 2.5 liters to excrete the solutes. So that is the osmolar clearance. Similarly, if a patient has got a high urine osmolarity of 425 and the total urine volume is 4.5, the osmolar clearance need to make the osmolarity 425 is 425 into 4.5, it is the volume, divided the plasma osmolarity is 290, gives rise to 6.59 liters. So this is the volume required to make the urine osmolarity 425 in a patient who has got a plasma osmolarity of 290. In the next example, we see that if the urine osmolarity is 250 and total urine volume is 4.5 liters, with a plasma osmolarity of 290, the osmolar clearance will be 250 into 4.5 divided by 290. So you can calculate the osmolarity. If you know the total urine volume, if you have the plasma osmolarity and urine osmolarity, you can calculate the osmolar clearance. So let us see what is free water clearance. Free water clearance is the volume of urine that is not containing any solute. So earlier itself we said urine has two components, the osmolar part which contains solutes and the free water which does not contain any solute. So this clearance is responsible for maintaining the plasma osmolarity normal and the plasma sodium normal. When you say somebody has got a free water deficit in the plasma, the volume, it means there is an intracellular dehydration which contributes to hypernatremia. So to repeat, when you say free water deficit or when you say hypernatremia, it is not actually the increased sodium that tells you there is a free water deficit in that individual. So when there is a free water deficit, the cells dehydrated, as we discussed in the chapter, when we discussed hypernatremia, that produces neurological manifestations. So what do you understand by the term positive free water clearance? Here, the urine is hypotonic. That is, the plasma has got a high osmolarity. Urine has a low osmolarity. That means the urine contains more water than what is required to excrete the solutes. So there is a hypotonic urine. There is a hypoosmolar urine. So to this urine, we have to remove water if you want to make it isosmotic to plasma. So when we say free water clearance positive, what we understand is the kidney excretes excess of water more than what is required for excreting solutes in sufficient quantity. That is called as free water clearance and it is positive. Similarly, when we say it is negative, the urine osmolarity is higher, it is concentrate. It is hypertonic to plasma, meaning the kidneys are retaining free water and excreting excess solute in a small volume of urine. In such a situation, you need water to be added to the urine to make it isoosmotic. So in simpler terms, if the urine volume is large and the solute load is less, the osmolality of urine will be low. In such situations, if you want to make it isoosmotic to plasma, you have to remove water. On the other hand, if you are excreting solutes in a small volume of urine, the urine osmolality will be high. And if you want to make it isoosmotic to plasma, you have to add water to the urine. That is what you understand or mean by positive and negative free water clearance. So free water clearance, to repeat, is the volume of urine contained in the 25 urine volume that does not contain any solute. And if the volume is large than the osmolar load, then it is positive free water clearance. And if the osmotic load is high and the urine volume is low, it is said free water clearance is negative. So let us see some examples. So before that, let us see what do you mean by this free water clearance. You take the ratio. If the free water clearance 0, that means it is isoosmotic to plasma. The kidney is neither concentrating or diluting, it is excreting the urine as such. If the free water clearance is greater than 1, that means there is a production of hypotonic urine. That means the urine contains more water and you have to concentrate on conditions like diabetes insipidus. So, few illustrative examples. In a patient with a urine osmolality of 250 osmoles and the urine volume is 3 liters and the plasma osmolality of 300, the osmolar clearance, as we said earlier, will be 250 into 3 divided by 300 is 2.5 liters. But this patient is having a total urine volume of 3. And as you note, the urine osmolality is 250, which is less than the plasma osmolality. That is, the urine contains more water. So if you say this patient has got a positive free water clearance, and if you want to make this urine isoosmotic to plasma, you have to remove 500 ml from the urine. Again, the concept is very simple. When you say free water clearance is positive, that means urine contains more water much more water than that is required to excrete the solutes. So the free water added to the urine is very high. And we know the hormone that is responsible for retaining excess water, antidiuretic hormone. And there is a deprivation of antidiuretic hormone action. That may be the reason why this patient has got a positive free water clearance. In a patient with a urine osmolality of 250 and a total urine volume of 2 liters, if the plasma osmolality is again 290, we see the urine osmolality is low. Again, to repeat, when the urine osmolality is low, it contains more water than plasma. And the osmolar clearance in this patient is 1.79 liters. The free water should be the total urine volume minus the osmolar clearance, which is 210 ml. So again, if you want to make this urine isoosmotic to plasma, you have to remove 210 ml that is excreted in excess by the kidney. So here the free water clearance is again positive. So the bottom line is, if the urine osmolality is lower than the plasma osmolality, that means the urine contains more water than that is required. And maybe it is probably because of the deficient action of antidiuretic hormone. So what are the causes of urine free water? That is, free water clearance is positive. That means urine contains excess water. Patients with tubulointerstitial disease who have concentration abnormalities, patients who are receiving osmotic diuretics, patients who are recovering from acute kidney failure, all those patients have a high free water loss along with the solute loss also. So in this example, we can see the urine osmolality is 425, the total urine volume is 4.5 liters, and the plasma osmolality is 290. That means the urine osmolality is much higher than the plasma osmolality. Again, that indicates the urine contains less water than what is required to exceed the osmotic load. That is why the urine is concentrated and the osmotic load is high and the osmolality is high to 425. So this patient, urine volume is 4.5. The osmolar clearance should have been 6.59 liters. But this patient has got only 4 liters of urine, 4.5 liters of urine. So this patient is retaining 4.5 minus 6.59 will be around 2 liters. So the patient should have excreted 2 more liters to make it isoosmotic to plasma. So this is a negative free water clearance. That is, patient is retaining water which should have been excreted to make the urine isoosmotic to plasma. This is called as a negative free water clearance. So in simple terms, if somebody has got a urine osmolality which is higher than the plasma osmolality, that means the urine water content is less. That means the kidney is retaining water, and the probable cause usually is antidiuretic hormone, which is acting to reabsorb water and retaining it. So what are the factors that regulate free water clearance? We all know that dehydration, hypernatremia, the water content, there's a water deficit. Patient has to retain water. So the ADH acts and absorbs water. Syndrome of inappropriate ADH secretion, we all know. ADH is secreted inappropriate to the plasma osmolality. That is why the plasma osmolality is low and the urine osmolality high. So that is another condition which you have to think. The free water clearance is negative. Kidney diseases, mainly tubular interstitial diseases, as we mentioned earlier, which can make the tubules insensitive to ADH, some medicated drugs, etc. So when you encounter a patient with polyuria, you have to calculate the osmolar clearance, you have to calculate the free water clearance, you have to find out whether it's a positive free water clearance or a negative free water clearance. If it is positive, that means the patient you have to look for more water in the urine. If it is negative free water clearance, less water in the urine. So the causes depend on the situation. So let us see a problem now. This 60-year-old lady was admitted with loss of balance while walking. She also gives history of cough, hemoptysis, and normal urine volume. She has normal GFR. Sodium was 150, that is hypernatremia. Urine osmolality was 450. 24 urine output was 2 liters per day. And plasma osmolality was 225. So it's very obvious that she has got a very high urine osmolality. That means ADH is acting in excess. It is retaining water. So if you calculate the free water clearance also, that tells you the free water osmolar clearance is 2 and the total urine volume is around 2 liters. So 4 minus 2 will be 2 liters. So the 2 liters of water has to be added to make this urine isotonic to plasma. So this tells you very clearly there is a negative free water clearance, suggesting that ADH is acting in excess. So in a 60-year-old lady who has loss of balance, which can attribute to hypernatremia. When you say hypernatremia itself, as we suggested earlier, it says free water deficit. And when you say free water deficit, you are calculating the free water clearance. The free water clearance also tells you are the correct direction. There is a negative free water clearance. So this patient has to be given around 2 liters of free water to make the sodium normal. So probably what she has is a syndrome of inappropriate diuresis or a syndrome of antidiuretic hormone. Inappropriate antidiuretic hormone. So this is the usefulness of this calculation. When you calculate the free water, that also can tell you how much of free water has to be given to this patient to make the plasma osmolality normal, to bring back the plasma osmolality to 290, and the urine osmolality down to its normal state. So that is the usefulness of this. Similarly, look at this 45-year-old gentleman admitted with change in mental function and excessive urine output. He was a schizophrenic of long duration on medication, and his urine osmolality was 100 osmoles per kg. Plasma osmolality was 290. 24 urinary output was 8 liters. So if you calculate the osmolar clearance, that is around 2.75. And the free water clearance is clearly positive because the total volume of 8 liters, which is much more than is excreted the osmotic load, which requires only 2.75 liters. So he is excreting in excess 5.25 liters. That is why his sodium is low, osmolality is low. So what you have to do here is you have to go through the medications. There are certain medications which can suppress ADH. So if somebody is schizophrenic, he's on antipsychotic medication, go through the drug list to find out, is there any medication which is suppressing the action of ADH? So anything that can produce what is earlier called as a nephrogenic diabetes insipidus. So this is a usefulness of calculating the free water clearance. That tells you the ADH action is inadequate or this patient has got a psychogenic polydipsia. We know that psychiatric disorder patients have a tendency to drink excess of water. When they drink excess of water, this excess of water has to be excreted to bring down the plasma osmolality to normal. So that may be one of the reasons why this patient has got a high urine volume. So what are the causes of water diuresis? As we said, this schizophrenic patient can either have a primary polydipsia, increased thirst leading to increased water intake, or it could be ADH deficiency. Earlier we called as a central diabetes insipidus. Now it has been termed as a vasopressin sensitive diabetes insipidus. Or it can be a decreased response of the tubules to antidiuretic hormone or vasopressin, which was earlier called as a nephrogenic diabetes insipidus, which has been renamed as a vasopressin resistant diabetes insipidus. So water diuresis or aquaresis has got 3 important causes. One, it could be increased water intake, as in polydipsia, primary polydipsia, or it could be increased suppression of ADH from the hypothalamus, which is now called as a vasopressin sensitive diabetes insipidus, or the tubules are insensitive to action of ADH, which makes it a vasopressin resistant diabetes insipidus. So we have now drugs called aquaretics, tolvaptan, conivaptan, etc., which is usually given for hyponatremia. So how do you approach polyuria based on urine osmolality? On the left-hand side, you have the urine osmolality. If the urine osmolality is less than 150, it can be either diabetes insipidus or excessive water ingestion, as in psychogenic polydipsia. On the right-hand side, we have an isoosmolar or hyperosmolar urine, which tells you there is a solute diurese. On the right-hand side, we have a urine which has an osmolality equal to plasma or increased than plasma. So next step will be, we said earlier, the main contributing solutes to urine osmolality are sodium and potassium. So if you measure osmolality 2 into urine sodium plus potassium, which is equal to urine osmolality, that means probably this is a salt and water diuresis. The usual cause being diuretics, interstitial disease. To repeat again, if the urine osmolality is equal to plasma osmolality or higher than plasma osmolality, next step is to measure the urine sodium and potassium. If the urine sodium plus potassium into 2 is equal to urine volume, we know the main contributing factor to the osmotic load is salt and water. So the causes of increased excretion of sodium, potassium in the urine are diuretics or some interstitial disease which can interfere with the reabsorption of sodium potassium. On the other hand, if you measure urine sodium potassium along with chloride, or first you see the right side, if the urine sodium plus potassium into 2 is less than the urine osmolality, that means we know that there is some other solute which is contributing to osmolality. To repeat, urine osmolality is mainly contributed by sodium and potassium, which is 2 into urine sodium plus potassium. You are also measuring urine osmolality using osmometer. If the 2 into urine sodium plus potassium is less than the measured urine osmolality, that means the culprit is not sodium or potassium. There is some other solute that is excreted in urine. So we earlier said there are a few causes which can do that. So go through the list and exclude one by one. If somebody has got a urine sodium potassium less than urine osmolality, then just urine chloride. So if the urine chloride is more than urine sodium and potassium, and the urine pH is less than 7, that means it could be a ketoacidosis or some drug anions, etc., which is excreted in the urine. But if the urine sodium and potassium is more than chloride and the urine pH is more than 7, it is usually showing the presence of bicarbonate in the urine, as in renal tubular acidosis. So isoosmolar to plasma or hyperosmolar contains non-electrolyte osmoles. There the urine osmolality will be more than 2 into sodium plus potassium. Diabetes mellitus, renal glycosuria, drinker type of hyperglycemia, etc. are important causes. If the urine urea more than 100 osmoles can also contribute to this situation. So very simple is you have to measure urine osmolality. You have to measure urine sodium potassium chloride along with pH. You find out which sect of the figure it belongs to. If the urine osmolality is less than 150, straight away think about diabetes insipidus and psychogenic polydipsia. If it is more than 300 or between 150 and 300, you have to better concentrate on the right-hand side. If the urine sodium and potassium is equal to urine osmolality, we know that diuretics may be the reason. Renal chronic tubular interstitial nephritis or acute interstitial nephritis can also do the same. If the urine sodium potassium is less than urine osmolality, that means there is some other osmotic substance in the urine. It could be glucose, either due to diabetes mellitus, it could be renal glycosuria or excessive ingestion of glucose as in trigger type of hyperglycemia. If the urine contains more than 100 osmoles of urea, or if you have given mannitol, that can also produce a high osmolality. Now, just see what is happening to this patient. This is a 65-year-old man who developed hemiplegia. He was also aphasic. He was fed through a rice tube feeding and was discharged. 7 days later, he was readmitted in a stupor state. There was no focal neurological deficit. He was hypovolemic. Urine volume was around 3 liters. So straight away, by definition, anything more than 3 liters contributes to polyuria. So this patient had a polyuria. Blood glucose was 100 milligram. So probably it is not a diabetes mellitus contributing to increased volume. Creatinine is 1.1. That is, GFR is normal. So probably interstitial disease is not the reason. Urea is only 40 milligram. Sodium, as is very obvious, is 150. That is hypernatremia. When is hypernatremia, that there is a free water deficit. That probably is the reason for worsening of his neurological status. And the plasma osmolality, as you see here, is very high, 312. So this patient has a normal volume status, severe hypernatremia, disproportionate elevation of urea and polyuria. Hypernatremia is what you have to evaluate here. So first is the ECF volume. So here the patient had got low skin turgor, diminished urine also. Probably it is a hypovolemic hypernatremia. You measure the urine volume, polyuric 4 liters, urine sodium 120, urine potassium is 40. So urine osmolality measured is 500. And if you compare that with urine sodium plus potassium into 2, which comes to 320, 120 plus 40 is 160, 2 into 160 is 320. The urine osmolality is much higher than 2 into sodium plus potassium. That indicates the polyuria here is not due to increased excretion of sodium and potassium. It is due to some other osmotically active particle in the urine. Again, to repeat, as is obvious from the history, the patient has got a polyuria as evidenced by urine volume of more than 3 liters. If you measure, they measured the urine osmolality, which is 500. If you calculate the urine osmolality is 2 into sodium plus potassium, that is 320. And the measured osmolality is much higher than the calculated osmolality, thereby indicating this patient's urine contains some other osmotically active particle. So, what is the next step? Test for osmotic solutes. There is no history of administration of osmotic agents or diabetes mellitus. Blood sugar was normal. Hence, the other important osmotic solute, urea, was measured. Urine urea was 400 milligram per day, suggesting increased excretion of urea. The high urine urea in this patient was derived from the high protein feeds. This because the patient is on right stool feeding. The relatives always are worried about protein energy malnutrition, and we also have a tendency to prescribe high protein feed. So that would have resulted in a high urea. To make the urea normal, this urea has to be lost in the urine. So probably it was a solute diuresis. That is why the urine sodium potassium was less than the urine measured osmolarity. So hypernatremia was corrected by infusion of 5% dextrose. So this is the usefulness of polyuria approach in the diagnosis of hypernatremia. You can find out what exactly is the cause of hypernatremia. Depending on that, you can address the management. So this is the algorithmic approach. Confirm polyuria. That is always done by measuring the 24 urine volume, especially in children. Parents say, my child wakes up in the night to pass urine many times, much more than the other sibling of his. So that may be just an increased frequency by habit. So you don't take into account that is polyuria. You have to essentially ask the patient, the parent, to measure the urine volume and to confirm that it is more than 2 ml per kg or the per meter square, whatever it is, and confirm it is polyuria. So having confirmed it is polyuria, you have to measure the plasma osmolarity and urine osmolarity, which can be done using an osmometer. You can calculate the osmolar clearance and the free water clearance. If the urine osmolality higher than the plasma osmolarity, look for solute diuresis. As in diabetes mellitus, the causes I have discussed earlier also. To recapitulate, it can be excessive urea, it can be radio contrast, hypercalcemia, high protein diet, as we said in the previous patient, or somebody is recovering from acute kidney injury, or mannitol is usually given for intracranial pressure. If the urine osmolality is less than plasma osmolality, it is a dilute urine, water diuresis, lack of ADH action. It can be diabetes insipidus or a psychogenic polydipsia. So how do we evaluate? This is what we discussed now. Now let us go to another case before we see this. This 25-year-old lady was admitted with history of polyuria. Clinically, she was urolemic. Systemic examination was unremarkable. The lab parameters are RBS is 95, creatinine 1.1, urea 25, sodium on the upper limit of normal 145, plasma osmolality again on the upper limit of normal 300, urine osmolality is 100. Because I can't interact with you. What is Can anyone of you say what it is? Anybody? Can you unmute and say what it is? Can you hear me? So she had polyuria, normal GFR with normal plasma sodium, and serum sodium osmolality in the upper limit of normal. So first step, as we said, is ECF volume, which is U volemic. Measure urine osmolality, urine sodium, urine specific gravity. The urine osmolality was 100, urine sodium was 10, and 24 urine volume was 6. So here is a lady with a urine osmolality of 100, which is much less than the plasma osmolality. A dilute urine, as evidenced by a low osmolality and a specific gravity of 4.005. The urine sodium is also low, only 10. So low specific gravity, low urine osmolality suggests the patient is unable to concentrate urine. Her GFR is normal and urine sodium is low. That shows the renal mechanisms are intact because the kidney is absorbing sodium. The tubules are reabsorbing sodium. So it is doing its job correctly. So it is not due to a renal cause. Is it psychogenic polydipsia? Usually in psychogenic polydipsia, because the patient or the person is drinking excess of water, it will dilute the sodium in the plasma. So it is usually associated with low plasma sodium. In diabetes insipidus, on the other hand, because of deficiency of ADH, the patient is losing a lot of water in the urine. So the plasma gets concentrated and there will be hypernatremia. So the differentiation of psychogenic polydipsia producing polyuria from polyuria due to diabetes insipidus can be made out from plasma sodium or serum sodium estimation, which will be low in psychogenic polydipsia and it will be high or the upper limit of normal in diabetes insipidus. So what do you do next? So having said this could be a diabetes insipidus, we have to find out whether it is a vasopressin sensitive or a vasopressin resistant diabetes insipidus. This is done by the water deprivation test, which is called as a Miller-Moses test. The principle is very simple. You are dehydrating the patients. So when you are dehydrating, we said there is hypernatremia and the patient loses the body weight and the urine osmolality will drastically increase because the tubules are reabsorbing water. So usually when somebody is subjected to a water deprivation, the normal response we expect is increased reabsorption of water leading to a high urine osmolality, which should be 4 to 5 times greater than plasma. So, and this also will produce a reduction in body weight more than 3%. So that is why you should be carefully monitoring this patient by hourly weight and at least 2-hourly osmolality, because otherwise you can create problems for the patient. The patient can go for, if it is diabetes insipidus, when you dehydrate, the patient will not be able to reabsorb. Patient can go in for severe hypotension and collapse. So you have to carefully titrate by measuring the urine osmolality and body weight. Decrease in urine osmolality from normal value or failure of osmolality to increase is diagnostic of diabetes insipidus. So you have made out a diagnosis. You have said this patient is not concentrating urine. The defect is due to antidiuretic hormone. So how do you proceed next? You have to find out whether the ADH is not coming from the hypothalamus pituitary axis or the ADH is there, it is not acting on the renal tubule. How do you do that? You administer exogenous ADH 5 units subcutaneously and measure the osmolality. Normally, the osmolality increase will be less than 9%. If the patient has got a central diabetes insipidus, because there is no ADH, once you give 5 units of ADH, the osmolality will increase by more than 50%. That shows there was no ADH. You are giving ADH, that ADH is acting on the tubules and the urosmolality has gone up by more than 50%, thereby showing the patient is reabsorbing water and it's getting corrected. If it does not rise, even with your water deprivation test, as in this patient, decrease in body weight reduced from 50 to 48 kg, urine specific gravity was 1.005, urine osmolality before was 50, after ADH was 75. So there was an increase in urine osmolality after ADH by 50%. So diagnosis here is central diabetes insipidus. So if you go back to the chart, polyuria more than 3 liters in 24 hours, measure urine osmolality less than 250, low serum sodium, it could be a polydipsia due to psychogenic cause or neurological causes. If it is not due to psychogenic polydipsia, you have to suspect diabetes insipidus. If it is diabetes insipidus, you have to make out whether it is central diabetes insipidus or a nephrogenic diabetes insipidus. You give subcutaneous ADH and find out the difference. If the urine osmolality is more than 300, straight away look for a solute diuresis. You are excluding psychogenic polydipsia, neurologic causes like hypothalamic disease or tumors, etc. for increased thirst. You are also excluding vasopressin sensitive and vasopressin resistant diabetes insipidus. You concentrate on solute diuresis. So, the last 35 minutes or so, I was just telling you what is polyuria. How do you do various definitions? Polyuria, nocturnal polyuria or nocturia, pollakiuria. What is osmolar clearance? What is free water clearance? What is the importance of finding out the osmolar clearance and free water clearance? How do you diagnose the cause of polyuria based on urine osmolality? And how do you differentiate diabetes insipidus from of central origin, that is vasopressin sensitive? In that case, the treatment could be vasopressin administration by nasal insertion. If it is due to vasopressin resistant diabetes insipidus, you have to find out the cause of the kidney, why the kidney is not responding, and then you have to use appropriate drugs. Thank you for your patient listening.